Welcome into Eye.Talk.Tech, where we explore the intersection of eye care and technology. I am your host, Dr. Griffin Christensen, and we know that myopia management didn't happen overnight. It's the results of decades of science and clinical trial and error. Our guest today is someone who has been in the trenches since the beginning, Dr. Tom Aller. His colleagues I've heard throw around the term trailblazer in the field. He's known for his any plus, any place philosophy and his work with industry legends like Dr. Brien Holden. Dr. Aller, first of all, welcome. How are you doing today?
Just fine. Beats working.
Yeah, well, we're happy to have you here. And like I said, you're referred to as a trailblazer in myopia management. But why do you think that label's maybe stuck, and what does that mean to you to hear that?
Means I'm old. Yeah, they start giving you, honorary lifetime achievement kind of things, and then you really have to get out of your denial state and say, well, I've been at it long enough to be a trailblazer. But I have a very I don't know, stubborn personality, maybe. Brien Holden was a bit like that as well, I think. But when I was in school, back in the 1980s, and way beyond that, really, the prevailing wisdom was that myopia was just a genetic condition. You couldn't do anything about it. It increases if it's going to the age of cessation, which was allegedly at the age of 16 or so. Anybody trying to do anything about that was a fraud or a charlatan. So that's what I got out of textbooks and most of my professors. I went into optometry peripherally, I guess, as influenced by being an ortho-K patient. So that was way back, PMMA lenses, daytime ortho-K, but I thought it was pretty cool to go through high school, without glasses on, as that was in the back of my mind. And so,
Oh, wow.
yeah, so I don't, I don't think I really thought then that I should go into optometry, but it was a positive experience for me. And, anyway, so just go to optometry school. I had an interest in research before I went to optometry school, and then I decided that meaningless research, chasing grants, the academic life wasn't really for me. Um, you know, Picking research topics to fit a grant. I was in animal behavior, so I was going to teach Coco the gorilla to write Shakespeare or something, which would have been interesting to me anyway. Um, but all they did is let me work on bugs. So graduate from Berkeley. Berkeley had an ortho-K study at the time, and they were mostly negative toward it. No one was really thinking of it as a myopia treatment. But when I got out in practice in the Silicon Valley, or Northern Silicon Valley, none of my patients seemed to stop at the age of 16. So after a few years, I had to confront the question, well, am I just a lousy optometrist, or were my professors and textbooks wrong? So naturally, I decided I was not a lousy optometrist. The textbooks were wrong. Hundreds of years of research and all of my professors were wrong. And I should try to do something about it. And that's what got me started into very early use of bifocal glasses, but only in a population that seemed to be amenable to treatment. So these are patients with esophoria or esofixation disparity at near. And I figured, well, if it works for them, even though they're not using the bifocals correctly, these kids are raising their chin and, not raising their chin and doing all kinds of stuff. I just surmised that a bifocal contact, which is 360 degrees, might be better. And so it just started with that, with a very modest kind of bifocal contact. Um, and I got just shocked by how much vision changed. Progression dropped just outrageously, really, in this particular patient population. So I started collaborating with a professor at Berkeley that I knew had an open mind. He was a binocular vision professor, Dr. David Grisham, and we started to do a retrospective study. And we went several years like that. He was supposed to get some students to do all the research for us, but and I ended up having to do it. But when we finally finished that, we saw a 90% reduction in the rate of progression
Wow.
So before and after, it was so ridiculous. Nobody believed it. You can't believe the names I got called, for daring to even just talk about it. It's really, I don't know, laughable. But um, then we got a study funded by industry, and we produced a randomized controlled clinical trial and an identical twin pair that showed dramatic changes when switched to bifocal contacts. Even that wasn't believed. I think in retrospect, I should have lied about it. I said, look, we found 40% change. And, oh, wow, that's amazing. Here's the Nobel Prize. But you come out with 80%. You come out with eyes shrinking, which was ridiculous at the time. And it's just hard. It's hard to change established science. I've heard it analogized
Sure.
to steering a battleship. So maybe my stubborn personality, maybe knowing what I knew, that I knew what I was finding, and I knew I wasn't lying. Just kept me going.
You had a stick to itiveness for sure.
There you go.
That's quite an origin story. And I'm curious what your progression was like. I was an ortho patient growing up. My dad's an optometrist, and he put me in a Paragon CRT lens actually as a high schooler. I'm curious what your progression was like as a patient. Did you see a halting of your myopia progression?
I don't think I analyzed it. Yeah.
Sure,
Um,
sure.
Back then I was
And then
wearing
the other
daytime.
thing, you
Yeah.
mentioned. Oh, go ahead.
Oh, I was going to say I was wearing daytime ortho K. So when you're looking through that, you just have a single vision lens. So I didn't have an
Gotcha.
anti-myopia signal until I removed it. And at that,
Sure.
without reverse geometry, it was just a mildly flat center. I don't think I can find my topographies from my old optometrist, who's retired in
Sure.
Florida now. So yeah, I don't think it had any effect.
It didn't have that same, peripheral blur effect and so forth. And the other thing you mentioned, in some of your studies, you actually showed some regression of myopia. You had eyeball shrinking that actually occurred.
Yeah, that's one of my taglines. Shrinking eyes for 30 years, but it hasn't caught on like some of my others. But that was, when we found that, my co-authors, Professor Wilsett and Maria Liu at that time, um, they were a little bit hesitant to call it shrinking. So they like to call it progressed by insufficient amounts or something like that. Um,
Sure.
but yeah, we saw shrinking, and now we know, mostly we know that that's because the choroid thickens, and we measure from the front to the front to the front to the back. So if the choroid thickens, it pushes the retina forward. So you get an optical shrinking. Um, but I found in a lot of cases that seems to be semi-permanent. The question is, how does it become semi-permanent? Does the sclera remodel in that new shape? Does the choroid stay thicker, which is hard to imagine because it's vascular and can respond in minutes. So that's still a mystery, but yeah, definitely eyes will shrink. Small amounts.
Wow. And at what point here did you cross paths with Brien Holden, and could you speak a little bit to his impact on the field?
Yes. Well, that was another origin story. So I've been an inventor for years, a would-be inventor, I guess. My first invention in optometry school, I like to call the alligator clip. So it's just a clip you put in your pocket, and then you put your glasses in there, and then when you bend over, your glasses don't fall out, which I thought was great. And that's when I met my patent attorney. And he said, well, that's a pretty good idea, but some engineer in 1917 didn't like his slide rule falling out of his pocket, so he beat you to it.
Mm.
So, you win some, you lose some. But I did get a patent on my use of bifocal contact lenses for the control of myopia. It was either the first or the second patent in the area. And I shopped it around to the various companies, didn't get really any bites. And then I was at a Academy of Optometry meeting. I think it was in '05 or '06 in Denver, and some friends of mine came up to me. The listeners will know Pat Caroline if they're in the field. Jerry Ledgerton is a legendton in the field of contact lenses, if I may say. And they said, "Hey, Tom, you really got to go see Brien Holden. He's putting together this team, you know." And I said, "Well, that's a little surreal because at the time, and for all time, really, he's a, acknowledged giant in the field." And so I said, "Oh, what the hell? I'll go. I got a patent. Maybe we'll see what happens." So I go up to him at the Australia party. If you've been, that's a raucous, big production, bands and noise, and he's in his element there and holding court. And I went up to him and I said, "I hear you're dying to meet me." And he said, "Now, why the hell would I want to meet you, mate?" And then I gave him my name and he acknowledged, yes, he did want to meet me. So we started to chat really loud. And I said, "Well, if you really want to talk, let's get out of this party, go in the hallway." So I might be the only person ever to drag Brien Holden out of his own party. And so we sat for 2 hours outside in the hallway, hammered out a handshake agreement, which led to God. Well, still I have an involvement with BHVI, but 10, 15 years of just a wonderful experience with him, all the Aussies and the international team that he put together. It it was an experience that never could have dreamed would have happened, you know, but it was great.
Well, yeah, we were fortunate enough to highlight the inaugural Brien Holden Founders Award dinner this year, before AOA. Felt privileged to do that. So fun to keep his legacy alive on the show here and in clinical practice, of course, as well. Let's talk a little more science here. Earl Smith is a name that's come up at doing research in preparation for the show here, and maybe you could inform our listeners a little bit what his research revealed about how eye growth is controlled, and why was the discovery of local retina control important? Do you have any thoughts on that?
Well, so Earl, among others in the animal research field, was known for showing that you can alter the development of a young animal's eye, by altering the focus on the back of the eye. So that's been done by many researchers in many animals. All animals respond the same, basically, to focus and defocus and manipulating focus. So as those animal researchers started to show that you could alter the development of the eye with lenses, it started to, I think, um, move the field a little bit away from genetics or everything. Because if genetics were everything, you shouldn't be able to do that. So, but it's
Yep.
really an interplay, like most things, between genetics and the environment, most conditions anyway. And the eyes are like that as well. You're going to have a higher risk of developing myopia with myopia in your family and with certain behaviors. And then you can manipulate that optically. So one of one of the early innovative things that he was able to show is that you can alter the growth of local areas of the retina by just imposing defocus in one little area, and that particular part of the eye would change, would grow, outpouch, let's say. And that led to people thinking, well, you could probably target certain areas with defocused cues, for instance, without necessarily impacting the center. And then along those lines, he also might have been the first one to show that if you ablate the macular region in these monkeys, so they have no more macula, no fovea, they still reacted the same way to defocus into the environment. So they would immetrope eyes normally, and they would respond to lenses in the same fashion. So that led to the often maybe misunderstood conclusion from his research. He really only said that the central retina was not necessary to control the growth of the eye, and that led to maybe some interesting strategies. For instance, could you put the medicine out where it doesn't taste bad? So put all the medicine in the periphery, let's say. Maybe even align the image
Exclusively.
cell to the retina or bring it in a little bit instead of out, and the central retina would never notice it. And so that was sort of a design concept. Um, but he never said that you had to use a distance center lens, for instance, or that only distance center lenses can work. And a lot of our colleagues have that impression, and it's commonly stated uh, incorrectly, I would say, as the any damn plus, any damn place guy. There's a reason why I started saying that. But I
Yeah.
found every lens I ever used that was some kind of multifocal, bifocal, um, all kinds of weird designs, echelons, which, it's crazy stuff, Fresnels probably, all kinds of stuff works. And so I was never because I'd been doing this for 15 years before I even met Brien and Earl for that matter. And so they might have liked to see what you could get with a distance center design that was a little bit more conventional approach at the time, although they expanded their thinking, perhaps from my urging, as you'll see later. But yeah, Earl never actually said that it has to be distance center, which he told me recently as I was asking him about the early days.
So it was inferred maybe incorrectly. And well, and how does that relate? You mentioned the phrase any plus any place. What does that mean clinically, and why did that maybe meet so much resistance? Was it in part because of that misconception from Earl's work?
Yeah, I think we have a tendency to think of lenses when you look at a lens design and it has a ring, let's say, or several rings, and has distance in the center. I think we tend to think of that as like collimated light, like the central zone, just you plop it right on the retina, right? And then the peripheral zones, they're just going to land there. But light's coming in from all sides, from all kinds of distances. And if you actually look at sophisticated ray tracings, which is beyond my ability to create, uh, even plus in the center will affect mid periphery and periphery, and plus in the periphery. It's just it's not as simple as a 2D uh, image, let's say, of a multi-ring design, because we're not using, we would never use lasers on kids, right? No. Well, that's another topic for another subject, but yeah, so the light's not
But the
collimated, so it's all
environment
over the place.
certainly isn't a laser. No, that's an important aspect.
I like distance center
Well, and
lenses.
so then
I use them a lot. I wear one as a presbyope. And, but in my past, I probably used distance center more. Maybe I was thinking along the same lines, but when I needed a plus center lens for optics, or because of the material, or because I wanted a daily, which were mostly near center, I'd be happy to use it. And I never saw any kind of difference, even when I systematically looked at it in retrospective studies.
sure. In terms of, fitting in the real world, when did this any plus, any place, mentality kinda come about in your clinical practice, and how have you seen kids adapt to that sort of a design?
Yeah, well, I guess the other thing I'm allegedly known for, I don't know if this is PG or not. I'll make it PG. Kids just don't give a darn, and that's meant to put out the idea that kids are very adaptable. So the first thing companies do when they design these lenses, they find a nearby optometry student or a vision scientist, or a presbyopic vision scientist, and they say, try this new design on with all this plus in here and, weird stuff. And they say, oh, I can't wear this. But you put that same lens on a 6-year old or an 8-year old that's one diopter under corrected at the time of their exam. They get that extra minus. They adapt very quickly. So it's, um, I haven't found really any systematic difference between the visual acceptance of near center and distant center lenses in the pediatric population. I think for my presbyopes, uh, I doubt if there is a difference either. I mean, the number one multifocal contact for presbyopia is a near center lens. I think if it's still holding the top ranking for sales, so it people can adapt to a lot of stuff.
Sure. One, if any plus any place is always the moniker, the studies have shown that just under minusing a patient is not going to be effective for myopia management. How do you reconcile that and sort of this sort of confusion that we have to place upon the retina?
Well, that's another thing I like to talk about is confusion, um, because I think really the key is, and this may apply to other biological systems. I kind of get a feeling it might when your system is presented with two conflicting signals. Hey, I want you to grow. Hey, I want you to stop. I think in the eye, when you have those two conflicting signals, the eye probably defaults to stop or slow. And I think the principle might be, well, what would be the safer thing to do if your system can't decide how to interpret these conflicting images? And the safer thing for an eye to do would be to stop or slow, because excessively growing eyes lead to all sorts of problems, pathology, etc. It would not be a good system if that's how we evolve. So that's just kind of a way I think of it. But if you look at every optical treatment for myopia, they all involve conflict. So there's plus, there's minus, there's different arrays, there's distant center, near center. There's now one, as we'll talk about, as near center and distant center combined. So, and then there's eyeglasses with 1,000 multi little tiny dots that control myopia. And there were even some studies that showed if you intentionally put minus in these little elements instead of plus, you get exactly the same control. I mean, that's what you do when your mind is blown. I mean, if you never thought about
Yeah.
conflict being the mechanism, that finding would just be ridiculous. But it's a very conflicting signal when you put minus and or plus or both together. And so I think I think the eye just slows down or stops in response to conflict.
Conflict. I think that minus lenslet sort of study that you're referring to, that does really seem to be strong evidence in terms of what you're saying in this. When in doubt, stop. So if we create a little doubt in the retina, it seems to have positive benefit.
Seems like.
Now, in addition to that, you alluded to this lens design. I know you've been doing some work with Euclid, and along with Brien Holden Vision Institute, you were involved in the development of their latest myopia technology called a multi-step design. Can you tell me a little bit, well, what that process was like, first of all, and then we can get into the details of the design as well.
Well, so roundabout probably 2005, 2004, Brien Holden started to put together his team, directed at doing something about what they saw as a pending global pandemic of myopia. And he met Earl at a conference. Maybe they knew each other before, but something about, I can't recall whether it was Brian speaking or Earl speaking, but some of them must have said something really profound, and that got them working together. So I brought Earl Smith in, others from around the world, his own team, and which was a great team, a lot of talented people in optical physics and design of lenses and metrology and instrument manufacturing and just running clinical trials. So he had everything covered. And then there was me that they brought in. So I was sort of maybe the voice of the clinician and somebody with practical experience. Like I said, 15 years already before. Actually, we could never get Earl to put a contact lens on his eye. He liked to call them poison discs. So I'm not going to put a poison disc on my eye. And so that was sort of funny that he was leading the development of contacts, and he wasn't too fond of them. He does wear them now for scuba diving, so we've converted him.
You won
Um,
them over. Yeah.
yeah. So the process was so I was still in California. I'd visit Australia on request, which was always fun, and we'd have emails back and forth and discuss concepts and um, work on patents and all that kind of stuff, and talk about clinical trial planning and our various collaborations with industry. So I was involved in that as well, and so we had multiple designs. Um, I would say that they were more free as a group to consider ideas that are maybe way out there at the time. Well, all that we were doing was way out there at the time compared to what the traditional optometry, groups were thinking. But yeah, plus in the center, distance in the center, really high ads. Um, there were some ideas we kicked around that we didn't pursue that later became interesting products and designs by other companies. So um, I would just advise anybody in this kind of iterative process where you're in research and development to just broaden your horizon and don't discount things that seem a little bit strange because um, you never get a chance to discover it. So um, I find a lot of the development processes in this field seem to be a little bit restricted. A lot of it has to do you're on a budget. Somebody's wants to see a return, or you have investors, and sometimes you just have to make decisions as a company. Let's say a commercial company to just get something to market without playing around with thousands different designs. So
Sure.
that's possible.
And what was kind of the most promising design that was spawned out of this research and the assembling of the Avengers you guys sort of had there?
Well, we ended up with several designs in a clinical trial in China. So there were four designs with two different concepts. One was an extended depth of focus design, and the other was a multi-step design, which is what has come to market now with Euclid design. And within each of those, you could imagine something we might think would be um, more effective or less effective in terms of how much plus there is. So there have been animal studies that have shown, for instance, that it's not only the value of the plus that you're putting in front of the eye, but also the area. So there's a concept now of sort of a volume of plus, so there's a lot of these spectacle lenses now. They have all this little tiny little dots, thousands sometimes, and they're creating this plus that's in front of the retina. So the other thing that we wanted to look at is whether there'd be some advantages of combining mechanisms. So if you have a near center lens, well, one advantage of that is it's always present, influencing the eye because you can't avoid it. It's right there in the middle. And it's also largely influencing the focus in the posterior pole macular region where the photoreceptors are more tightly packed. So possibly you get a chance to, even with a smaller amount of plus over a smaller area, impact as many photoreceptors as something that's more widely distributed, where the photoreceptors are less dense, for instance. So that's a valuable concept, I think, with plus in the center.
Sure.
And yeah, the other thing is that no matter the size of your pupil, probably no matter where you're looking, it's always going to be there. You can't really avoid it. And
Sure.
with certain plus in the periphery designs, if your pupil's a little smaller, the way it would be when reading and accommodating, maybe you're cutting off some of that plus. And we see the impact of that in certain studies where they combine atropine in a very low dose, which is usually not effective, 0.1, let's say. Maybe all you're getting is mostly pupil dilation. But with certain designs, you're also letting in more signal from the periphery. But with a plus in the center, uh, I suspect if you had a lens that was only plus in the center, which again was fine with me when we had it, dilating the pupil only probably wouldn't add any
Mm,
effectiveness because you're getting the entire signal, even in a probably 3 or 4 millimeter pupil.
yeah. Well, and as compared to the time when you were an ortho K where that wasn't even a treatment for myopia or a managing technique, we now have a plethora of options out there and a lot of evidence, of course, too. But why do you feel maybe myopia management is still underutilized? And if an OD out there listening is unsure where to start, what might be the simplest first step for them?
Well, that's something I've wondered about for years. Like I say, it's hard to steer a battleship, or so they tell me, and there's so much inertia. Um, I think one problem is sometimes the messaging from specialty level practitioners at podiums and the like is that okay, you have to have a biometer, you have to have a topographer, you have to do ortho K, you have to do everything, you have to see patients every 3 or 4 months, you have to charge high level fees, and if you don't do that, you're not practicing myopia management. And I may do all of that. Um, and specialty level practitioners like to do all of that. And that's why they charge specialty level fees. And they also spend a lot of time with their patients. But I have a slide I often show. It's one of Earl Smith's monkeys uh, putting a contact on another monkey. And the title is Even a Rhesus Monkey Can Control Myopia by 30 or 40%. Because if you were to
Okay.
just put on a bifocal contact lens, something that's very easily tolerated, and you don't do anything else other than normal follow up, but a kid wearing contact lenses, they just need one follow up to see how the lenses are doing, make sure the eye is healthy. You wouldn't necessarily see them every 3 or 4 months to make sure the cornea is clear. You don't do that with adults. And kids are more compliant with contacts than teenage teenage boys or college students, for instance. So you get them started. You wouldn't necessarily have to see them. And then you wouldn't necessarily have to charge them specialty level fees. So the other expression I like to use, I borrowed from Nike, just do something. If everybody did something and the somethings are easy to do, they're even easier now with the new approval of the spectacle treatment for myopia. Um, if you just did something, even if you didn't do the follow up, even if you didn't check in 6 months, even if you didn't do biometry, you didn't do any of that, those children who may not have gone to specialty or may not have been willing to or might not have been able to afford it, they would have benefited by having a 40 or 50% reduction in myopia. I mean, everybody wins. So I'm not going to ever say to one of my colleagues that might like to start dabbling that, "Oh, no, no, you can't do that. You have to send all your patients to me." Well, I can't see all of your patients. Specialty
Yeah.
level ortho K practitioners can't handle the global myopia pandemic. It just cannot be done. Um, Ortho K. I love Ortho K. A lot of times I was sort of a bit of a pariah at the Ortho K conferences because I dared to say the word soft contact lens, but they still let me speak and I have great friends there and everything, but sometimes, Ortho K is great. I'm doing more of it than I ever did before. But if the only thing we could do to control myopia is to have specialty level Ortho K practitioners do Ortho K on everybody, they can't see all those patients. It's
Yeah.
so one thing is what's good for the optometrist practice or for themselves, what's good for the profession, what's good for society as a whole. Well, what's good for society as a whole is change this slope so that we don't have, 5 billion myopes by the year 2050.
Yep. Well, and I think there's certainly room to have that fit within a model that's beneficial for the practice and the practitioner as well, and have it come out as a win-win. And I think that's a tremendous call to action. Just do something. Dr. Eller, thank you so much for sharing your history today, sharing the science and your passion as well. If there was one final thought you wanted to leave practitioners out there with today, what would that be?
Well, I just gave you the money line, just do something. But there are more and more lenses available.
One, the science is there, the tools are there, and the kids need our help. So, Dr. Aller will make sure to post in the show notes some information about you and your work. And to all of our listeners, if you have any thoughts, please put those in the comments as well. Like, share, subscribe if you enjoyed the show. And we'll be back next time on Eye.Talk.Tech. Thanks so much.
All right. Thank you.